So if you'll recall, after we skipped a week, let's get ourselves oriented again. We were talking about non-gap acidoses, and we had embarked on a conversation of one of the renal tubular acidoses, that is the proximal RTA. We made several important points, including the fact that K wasting increases when you give alkali therapy to a patient with proximal RTA. We leverage concepts that we've reviewed in the past, so I won't pull out the marker board. Really, you're just augmenting the lumen negative charge of the distal nephron when you are giving alkali therapy to a patient with proximal RTA. We'll end our discussion around proximal RTA, reiterating a point that I believe I built our understanding around. That is, even though the acidosis of a proximal RTA can be reasonably mild, because you're able to eventually reach a lower bicarbonate load to the proximal tubule, and I can handle that bicarbonate load based on the tubular maximum of that diseased proximal tubule. I can handle all of the bicarbonate that is being delivered to that segment of the nephron, and so I do not continue to drop my serum bicarb, right? We highlighted how a proximal RTA fundamentally is a situation in which the proximal tubule has a reduced tubular maximum for bicarbonate reclamation, right? And so as long as the serum bicarbonate, or the bicarbonate delivery rate, I'll put it that way, is less than or equal to that tubular maximum, I can ultimately render my urinary bicarbonate to zero at that point, right? This goes to zero. But so again, I have a reasonably modest metabolic acidosis, but I have a massive amount of bicarbonate that I must give to try and increase my serum bicarbonate. Why? Because as soon as I give that bicarbonate, I exceed my tubular maximum, right? As soon as this starts to rise by giving alkali therapy, now I'm exceeding my tubular maximum, and then the bicarbonate in my urine is no longer zero, right? It's sort of an overfill. It's trying to fill a bathtub with an unblocked drain, okay? That's the analogy maybe I can come up with. And we use K citrate because there's usually accentuated K losses. Sometimes you can try and increase proximal tubular bicarbonate handling or reclamation through creating volume depletion. When I create volume depletion, I try to essentially increase my tubular maximum, right? By creating volume depletion, my transport of solute and water in the proximal nephron, which is regulated by norepinephrine, angiotensin II. These hormones are signals to the proximal nephron to increase reabsorption rates of solute and water, including bicarbonate. And so if I cause volume depletion, I may reduce the tendency to bicarbonate wasting, okay? Moving on to distal RTA, we can talk about etiologies by referring back to this summary table, right? So here we are we've left the row of bicarbonate loss, of which we had extrarenal bicarbonate loss, such as pancreatic fluid, which has a lot of bicarbonate in it, or diarrhea, lower GI losses. We talked about our renal losses, including the proximal RTA. Now we're in this row of causes of non-anion gap metabolic acidosis arising from impaired renal acid excretion, okay? And a distal RTA would be an example of that, okay? Now let me highlight that, rather than describing RTAs, distal RTAs, or even proximal RTAs with a numbering system, we often describe the pathophysiology of the RTA. Okay, so we can say that there is a secretory defect, which is a classic form of a distal RTA, which is traditionally referred to with the designation type 1 RTA, right? Type 2 RTA is the classic proximal RTA. I see that if we used a 2 here and an I here, I got to fix that. So again, type 1 RTA would be the classic secretory defect, in which I may have, for instance, a defect in the apical transport protein, vacuolar HATPase. Let's show our split screen so I can refer back to that. Right, so that's an apical membrane transport defect, but you can see that there are certain basolateral transport defects, an anion exchange transporter that can also be a root cause for a distal secretory RTA. Okay, so let's highlight those transporters so we get the visual. Here we are again in the collecting duct. Remember again, your acid excreting cell, alpha for, or A for acid or alpha intercalated cell. This is your deep nephron, typically in the deep medullas, where you're enriched for the presence of these intercalated cells. Here we have our apical transporters, so I can have a defect in this vacuolar HATPase. I can, for instance, start to create an autoantibody to vacuolar ATPase, such as has been described in certain patients with Sjogren's syndrome who have this distal RTA. It's not rare. You will likely see a patient with Sjogren's and distal RTA in your career. But you can also have transport defects in basolateral transporters like the anion exchange molecule here, or anion exchange transporter, that can be a cause of this secretory defect, type 1 RTA, distal RTA. Okay. So I've highlighted those transport defects. And then the acquired forms, I'm anticipating our discussion with this description of Sjogren's induced distal RTA. That, I would say, is one of your most common acquired forms of this secretory defect RTA. Okay. We have also published at our institution a case, one of the largest case series of lupus-induced secretory defects. Some of these patients have autoantibodies that are to SSA and SSB, similar to Sjogren's patients. They also seem to have a predilection to anti-RNP antibodies. Occasionally, we will have a scenario in which we ask ourselves, is the distal RTA the cause of nephrocalcinosis, or is the nephrocalcinosis the cause of the secretory defect? There's a chicken versus egg, or chicken and egg concept or discussion of which preceded which in certain cases of nephrocalcinosis with concomitant evidence of distal RTA. Okay. Amphotericin is a specific form of distal RTA, which is not traditionally known as a type 1 secretory defect. We'll talk about that so-called platinum or back leak RTA. Platinum drugs cause impaired urine acidification in the distal nephron as well. Again, amphotericin is most classically described as this back leak RTA. Okay, oops. Unless the secretory defect. And then I've highlighted the fact that although we think of carbonic anhydrase inhibition as a cause of proximal RTA, you have carbonic anhydrase throughout the nephron, and it is essentially what we describe as type 3 RTA, okay, because it's both a proximal and distal RTA, which you would understand when you realize that, again, intact urine acidification requires carbonic anhydrase activity throughout the nephron, including in the distal nephron. You have carbonic anhydrase expressed in the cell at the apical interface as well as the basolateral interface. Okay. All right. Occasionally, people have described an inherited defect in carbonic anhydrase type 2, which is the isoform of carbonic anhydrase, which is expressed in the distal nephron as well as the proximal nephron. So that's a classic yet rare form of a type 3 RTA. You can see, again, different isoforms of carbonic anhydrase throughout the nephron, but all of them have essentially are inhibited by acetazolamide. Some of the other carbonic anhydrase inhibitors may have specificity to some of the various isoforms, but carbonic anhydrase is pretty broad in its ability to inhibit many isoforms of carbonic anhydrase, causing essentially type 3 RTA physiology. You will expect to see, again, a high fractional excretion of bicarbonate, but you'll also see a urine pH, which is generally going to be elevated, right? Okay. Other forms of distal impairments and renal acidification is the so-called voltage defect RTA. We'll go through the physiology of this in just a bit, but let me just build out this framework. This is in which a case in which we cannot generate that lumen negative voltage, which favors the secretion of cations, including protons, as well as potassium. So the voltage defect RTA would be predicted to have a tendency towards both metabolic acidosis as well as hyperkalemia. Okay. We went over the fact that in a patient on our service right now who has a low urine sodium, that patient, an undetectable urine sodium, in this case because of low effective circulating volume of malignancy, that patient has impaired proton secretion. Okay, you can think of that as a form of a voltage defect RTA. Why? Because when I have low effective circulating volume and I'm delivering so little sodium to the distal nephron, I cannot reabsorb sodium via ENaC and generate that lumen negative potential difference. I create an impaired capacity for proton secretion. Okay, so low ECV, with low urine sodium, tends to cause impaired urine acidification as well as hyperkalemia. Okay, again, that intact proton secretion requires a ability to generate a lumen negative potential difference.
Is that in the absence of any other cause of metabolic acidosis? Always think the volume track.
Yes. So the question is, when I think if I can refine it is, if I have metabolic acidosis with a low urine sodium, is that sufficient to explain that phenomenon? Right? Is that fair? Because we see a lot of patients with volume depletion and low urine sodiums, and you're saying that you don't always see metabolic acidosis, right?
Correct, yes.
Yes. So,
they may give me more alcohol.
right. But the classic patient who's alkalotic is still receiving diuretics and has a urine sodium that is not low,
Okay.
right? So that is classic. But let's suppose you stop the diuretics. At that point, your urine sodium will go to 0, right? A patient who was diuresed with furosemide, got volume contracted, you stop the furosemide, their urine sodium will then go to 0, right? And in that case, they will have a tendency to impaired proton secretion, and the serum bicarbonate will start to fall, right? But there are a number of factors why that bicarbonate may start to fall, not just because I have impaired proton secretion if my distal sodium delivery is low. Okay? I'm not trying to gloss over your question. I want to make sure everybody understands that. In general, again, in order to achieve let's call it maximal proton secretion, you need to be able to generate a lumen negative potential difference. Okay, so the most common example in which I would see this is a patient who is managed with who has cirrhosis and then has diarrhea from their lactulose, right? So they're now generating acid from that diarrhea, and they develop a metabolic acidosis even before the spironolactone more easily than you and I, okay? Because what you and I would do is we'll manifest diarrhea, we'll be generating acid as well, because the loss of bicarbonate in my stool is the equivalent of gaining acid, but we will not get acidotic. Why don't we get acidotic? Well, because I'm not volume depleted that much, right? And I just increase ammonium excretion rates. I dump more acid in my urine, right? But if I get volume depleted or I have low ECV like cirrhosis, and you challenge me with an acid load from lactulose-induced diarrhea, I am more apt to manifest a metabolic acidosis because I cannot maximally acidify my urine. Does that make sense? So in order to maximally acidify my urine, I need to be able to generate a lumen negative potential difference to start favoring for the electrochemical gradient to favor more proton excretion. Okay? All right. In fact, one of the ways we test the efficacy of the distal nephron in dumping protons is to give loop diuretics plus mineralocorticoids. Okay, so you can do essentially look for maximal urine acidification, a urine pH that goes down as expected. I can do that by giving an ammonium chloride load and measuring your urine pH after giving ammonium chloride, meaning I challenge you with acid and I watch to see whether you can maximally acidify your urine. Another way I can do this in an ambulatory setting, because you can't find ammonium chloride for easy access, is I can give you furosemide and Florinef. That's the typical 1-2 punch. Okay, so by giving you Florinef and furosemide, I deliver more sodium to the distal nephron. The Florinef enhances sodium reclamation, generating that lumen-negative charge, and the Florinef also stimulates vacuolar HATPase, stimulating proton secretion. I should see, in a patient with normal response, I should see them being able to lower my urine pH maximally. That's one way you can elucidate in the ambulatory setting a distal RTA. Okay, just reemphasizing the generation of a lumen negative potential difference by reabsorbing sodium is essential for maximal efficacy in urine acidification. Everybody get that? Okay. All right, so type 4 RTA you can sort of think of as a voltage defect. The defect in this case is the low aldosterone, right? With low aldosterone, I cannot generate that lumen negative potential difference maximally to achieve maximal proton secretion, okay? And that carries a specific context. Normally, those patients have mild to moderate CKD and acidosis that is disproportionate to the degree of CKD. They're classically diabetics. Non-steroidals would be another instance in which I have hyporeninemic, hypoaldosteronism. Again, we'll talk a little bit more about those things when we get to the text. Calcineurin inhibitors can be thought of as a form of type 4 RTA. The aldosterone level with calcineurin inhibitors is variable. People have described low aldosterone levels, non-suppressed aldosterone levels. That's less consistent, so please don't anchor around you have to see hypoaldosteronism with calcineurin inhibitor-induced metabolic acidosis. Low molecular weight heparin is another example we'll talk about where I'm inhibiting aldosterone synthase. Okay. All right. Let's get to the text, and then maybe we'll circle back and fill out some of these things as we get through examples of distal RTA. So again, one form of distal RTA, if you want to use the numeric system, is the secretory defect, type 1 distal RTA. We've talked about both acquired and genetic forms. The genetic forms are the vacuolar HATPase, and we also have anion exchange defects, okay? Anion exchange defects and vacuolar HATPase. Okay. Here's the pathophysiology. These patients often have sensorineural defect or sensorineural hearing loss. There's a variety of genetic diseases that you'll start to put together in your knowledge bank or your memory banks that have a renal phenotype as well as a sensorineural defect, one of which is the Bartter syndromes we talked about, specifically the Barton mutation, or the two defects. You have to have biallelic defects in basolateral chloride transport. We went over that. I'll refer you back to your tubular transport map if you need to uh, uh, revisit that. But there are several things that can be associated with sensorineural hearing defects, including this HATPA genetic defect. We have a couple of these patients in our Parkland Renal Clinic. Again, basolateral anion exchange defects. We actually have a family of these in our Parkland population as well. And Orson actually published some of the science around specifically what was the anion exchange defect based on that family here at Parkland and KI. It's kind of interesting to connect the dots. I've encountered one of these patients who's pretty non-compliant and has come in multiple times with severe metabolic acidosis. And then I mentioned that carbonic anhydrase defects are distal RTAs as well as proximal RTA. We would count that as a type 3 RTA. Amphotericin toxicity is most classically a what's called a back leak defect, but people have also, put this in certain lists of distal RTAs as well. Okay. But again, we'll get to back leak shortly. The presentation, when you have a complete distal RTA, is typically a very severe metabolic acidosis. I mentioned that one of those non-compliant patients from this family of anion exchanger 1 defects has come in with profound metabolic acidosis to the MICU. Why is it that these patients come in with such severe metabolic acidosis? In this case, again, the problem is with my maximal capacity for proton secretion. We talked about how we have an obligate need to excrete protons, and that varies according to how much animal protein we eat, by and large. Okay, so if every day I excrete, let's say my defect in urine acidification is mild, relatively mild, I can only excrete, let's say, 50 millimoles per day of protons, but I generate 70 millimoles of protons. What happens is my bicarbonate concentration drops just a bit, right? But if you string, let's say, 3 months of that every day, input of acid or generation of acid exceeds my capacity for excretion of acid, then every day my serum bicarbonate drops more and more. And that's how I ultimately can manifest very severe metabolic acidosis, even though my generation rate is only modestly exceeding my excretion rate. Okay. That's not the case in the proximal RTA patients. Remember, the proximal RTA wastes some bicarbonate, but they achieve a new steady state in which the serum bicarbonate is dropped, but their distal nephron is still intact and can excrete the net acid load. Okay, that's why, again, your bicarbonate doesn't continue to drop with the proximal RTA. But with that distal defect, where I have that final capacity to match my generation rate. I can string several days of positive acid balance together and manifest a very severe metabolic acidosis. Okay. Similar to how I might have an impaired water excretion rate, right? An SIADH patient, you just need to string many days of water intake exceeding water excretion rates, and your sodium drops from that 135 down to ultimately that 110. It took me days, weeks, months to get there, right? Okay. So these patients will generally have a urine pH that is not maximally acidified because of this defect in proton secretion. You and I should be able to get into the 5 range and maybe even the upper 4s if you have a very healthy kidney. So when you see a patient who has a urine pH of 6, right, that's still acid urea, but that is abnormal for a patient with metabolic acidosis. In fact, that case series of lupus patients with RTA that we described, most of them had urine pHs of like 6, okay, sometimes 6.5, but it's not overtly 7, 8 in many cases. Okay, so look for more subtle forms of this. I think we spent last 2 weeks ago to talk about the urine anion gap. Hopefully you understand that. I believe, though, we did not broach the urine osmolar gap. We just limited our discussion around the urine anion gap. So let's quickly talk about the urine osmolar gap. The punchline, which I hope you recall from our discussion 2 weeks ago, is urine anion gap is your surrogate for how much ammonium is in the urine, right? NH4 plus. And that would be a negative urine anion gap that would correlate with, let's say, some ammonium in the urine, right? Okay. That urine anion gap derives from the fact that chloride, which is negatively charged, is balancing this unmeasured positively charged molecule in the urine. And so my urine anion gap, which is sodium plus potassium minus chloride, will be negative because, again, this molecule is not being is not a term in your urine anion gap equation. Okay, so negative urine anion gap indicates supposedly adequate ammonium excretion. The confounders are if I have another anion in my urine, such as ketones. Okay, in that case, chloride may not be so high in comparison to ammonia, in comparison to sodium and potassium, because there's another anion that's balancing those cations. Okay, classic of which is ketoacidosis. Right, so urine osmolar gap can capture this confounder. Okay, it's superior to the urine anion gap because it is not confounded by the presence of another unmeasured anion in the urine. Practically, though, the barrier that exists is that if you have glycosuria, you can't measure your urine glucose quantitatively. All you get is a qualitative test for I have some glucose in my urine. Okay, and so you can't use it for your urine osmolar gap calculation. So practically, urine osmolar gap is only helpful when you don't have glucosuria. Okay, how do we calculate a urine osmolar gap? Well, as the gap implies, we check the urine osmoles and we compare that to the calculated urine osmoles. Okay, urine osmoles are going to be 2 times my sodium. It looks very similar to your serum osmolar gap, right? Except because potassium in the urine is more than just a mere 4, you have to include the potassium term. Okay, when you're calculating a serum osmolar gap, we can usually disregard this potassium because potassium is relatively small. And so that's 2 times your sodium over your urea divided by 2.8 and your glucose divided by 18. Okay. Here we have to say 2 times sodium, 2 times potassium, because there's a fair amount of potassium in many urine set chemistries. Urea, also divided by 2.8. And then if you had a way to measure glucose quantitatively, you would put in the glucose term as well. But practically, we don't have that availability in our, I mentioned maybe Mayo can, but we can't. You can't get it timely. Okay, so this is how you calculate the measured osmoles in the urine, calculated osmoles in the urine, you compare it to the measured osmoles. And if there's a gap, you assume that there is another molecule that's present in the urine in large quantities, circulating with chloride. The two term is capturing the osmolar contribution of chloride in my urine. Okay, when I say 2 times sodium, 2 times potassium, I'm capturing the sodium chloride in my urine, the sodium or the potassium chloride in my urine, and the potassium and sodium ketones in my urine, right? Keto acid is captured by the 2 times terms, okay? So you can see that this is not going to be confounded by the presence of a keto acid in the urine, because my 2 times my sodium and potassium captures all of those anions. Okay? And so the difference between my measured osmoles and my calculated osmoles is going to be ammonium with chloride or ammonium keto acids. Anything that is negatively charged can balance that ammonium. That will give me some estimate of how much ammonium I'm excreting in my urine. Everybody get that? Okay. All right. Now, okay, so that's a good question. What is the value that you should hit? So that highlights the fact that a frequent statement that Orson makes is this is not a pregnancy test. It's not binary positive or negative. Urine anti-gap is negative, so it means that there's intact urine acidification or positive. It's not how life works, right? You should have a very robust ammonium excretion rate if you were doing the right thing, okay? You have the capacity, if you had totally intact renal function and you had a severe metabolic acidosis, you should be able to crank your ammonium excretion rates up from the average of around, in general, net acid excretion. Okay, we talked about that term. Consists of ammonium in large part, as well as the titratable acids, which I told you is mostly phosphorus in your urine. Okay, in the normal patient, roughly half is ammonium, roughly half is phosphorus. We said that if you're on a typical Western diet, your net acid excretion will be somewhere around 70 millimoles or 1 millimole per kilogram per day. So roughly 30 and 30, or 35 and 35, or 40. There's probably a little bit more ammonium in your urine than phosphorus, but let's just round it, okay? But you should be able to crank your ammonium excretion rates up to 200 plus. That's the kind of bandwidth you have. Okay. Osmolar gap should be 400 if I'm excreting ammonium chloride, right? So if I have a osmolar gap of 50 in somebody with a bicarb of, let's say 15, that's not normal. Okay. That being said, the real life is that, there's an error in your osmolar measurements. There's an error in your electrolyte measurements. So it's a messy landscape. Okay. Even, don't expect that if you divide your urine osmolar gap by 2, you get quantitatively an estimate of how much ammonium is in your urine. Not the least of which, again, is that's a spot specimen. It's not a time 24-hour urine. That's the other thing, right? So you'll have to make sense of all of that. Okay. All right. So hypokalemia is fairly consistent and is typically profound in the complete distal RTAs. Okay. How does that specifically happen is not well characterized. Okay. There is a complex set of explanations around that. And let's call it the older explanations that were not based on in biochemistry and mouse models of RTAs relies on this rationale that if I have a problem with cation secretion, okay, this is fairly intuitive, right? I'm reabsorbing some amount of sodium in the distal nephron. I'm generating a lumen negative potential difference. And potassium is one way in which that negative potential difference is balanced. Proton secretion is another way in which that negative potential difference is balanced. If I have impaired capacity for proton secretion, I have more K wasting. Okay, so that's a fairly intuitive explanation that is offered. Another way that that is explained is that when I have acidosis, I tend to have sodium wastage. That's well described. Okay, I often talk about it in its inverse. When you have metabolic alkalosis, you are causing diuretic resistance. Sodium reclamation throughout the nephron is upregulated in the setting of metabolic alkalosis. The opposite is true. If you have acidosis, you tend to have salt wasting. Okay, well described in balanced study. Okay, so if I have salt wasting, I'm delivering more sodium to the distal nephron. I have the capacity for this sodium proton exchange, let's call it. Okay, sodium reabsorption, lumen negative potential difference, augmented proton secretion, and augmented potassium excretion. If I cannot, secrete more protons because of a defect here, then I secrete more potassium. Okay, sodium wastage resulting in potassium wastage. Okay, there is more basic science, some recent papers that argue that there is a disturbance of autocrine signaling in the distal nephron that revolves around ATP metabolism. It's pretty complicated. Okay, but there's a mouse model that shows that K wasting occurs when you knock out vacuolar HATPase. All right, nephrocalcinosis is also fairly common in patients, and kidney stones in patients with distal RTAs, and often is the presenting feature of a distal RTA, right? You don't feel the metabolic acidosis, but you feel the kidney stone. And so these patients can manifest as a first presentation with kidney stones. The reason why they form kidney stones is because that relatively alkaline urine reduces the solubility for calcium phosphate. Okay, so when we talk about nephrolithiasis, this will come full circle, but I'll just anticipate that conversation with this statement that calcium phosphate is less soluble in more alkaline urine. Okay, the most common defect in calcium phosphate nephrolithiasis is a inappropriately alkaline urine, or RTA, or even incomplete RTA. Okay. These patients also will tend to have hypocitraturia. I'll make that I'll reinforce that in our discussion around nephrolithiasis, but any cause of metabolic acidosis, any cause, will tend to reduce your urine citrate through mechanisms involving proximal tubular physiology. We'll reinforce those things when we talk about nephrolithiasis. Okay, but any cause of metabolic acidosis, including GI losses, will tend to make my urine citrate very low. Treatment. We don't have to give as much alkali as proximal RTAs because they don't have that overflow. They don't have that bathtub with with a drain that's open, right? These patients, you simply need to match their acid generation rates, right? Or approximate it, right? If the kidney has some capacity for acid excretion, you need to give less alkali, but you shouldn't have to give more alkali than how much they generate in order to achieve acid balance in these patients, acid-base balance. Okay. Often we're giving it in the form of K citrate. Often we can't give it all as K citrate and often we cannot completely normalize the serum bicarbonate because as we give more base, what happens to urine pH? It goes higher. What's the downside of that? More kidney stones, more nephrocalcinosis. Many times in these distal RTA patients, we don't try and normalize their serum bicarbonate because as we raise the bicarbonate a bit, they will tend to have more alkaline urine, predisposed to more kidney stones. Okay, so most of the time we do not give K citrate to the point of normalizing K and bicarbonate. Often, at least in my practice, it requires a mix of KCl and K citrate, right? Because again, I don't want the bicarb to totally normalize because the urine pH is going to 7.75 as I'm giving that. So I fill the gap in the K with KCl at that point. All right. I think I made this point. Yes. All right. Moving on to incomplete RTA. Unless there's a question. Any questions? Okay. Incomplete distal RTA has some controversy around its definition and maybe even existence. And so there's not uniformity of, let's say, understanding of the presentation of incomplete distal RTA. Okay. However, I think the most common way that we describe this syndrome is that this individual has a serum bicarbonate which is normal, but a urine pH that is typically on the high side. Okay. Now, when you take these incomplete RTAs and you put them on an Atkins diet, or they start to have diarrhea, meaning they start generating more acid than the typical 1 millimole per kilogram per day because of that ketoacidosis, starvation ketoacidosis, or that, low carb induced ketoacidosis, then they can manifest an overt acidosis. Okay. So they have diminished capacity to excrete acid. And again, as long as the acid load is relatively modest, I'm able to achieve a normal serum bicarbonate. I just can't maximally acidify my urine. So again, you can say, is this really a thing, or is this just, a distal RTA with a modest acid load? But as soon as you get a more significant acid load, you eat more animal protein, you present with all the features that we would call a distal RTA, right? A bicarb that's low, a urine pH that's high, hypocitraturia, kidney stones. It looks very similar, right? Okay. So again, some of the pathophysiology is controversial because I don't think there's uniformity of understanding of incomplete distal RTA. But one description of the pathophysiology is that these patients, although they cannot make their urine pH drop maximally into the low fives, right? They can achieve balance, acid-base balance, by simply upregulating ammonium excretion rates. Some people have argued that that's why this deserves its separate category. Okay, let me now contrast that with the distal RTA. Right, we said that distal RTAs are going to have urine anion gaps, or maybe I didn't make this point enough. Urine anion gap in these individuals is going to be insufficiently negative or overtly positive. Their urine osmolar gap will be small. So what does that tell you about ammonium excretion rates? Low. Low. Okay, good. All right. Now, you can ask yourself, sometimes Orson's brings this up, so I'm preparing you. Look smart in the acid-base lectures, okay? Remember this stuff. You can ask yourself, well, this doesn't make sense. Why? Because if distal RTAs are a problem with simply dumping more protons, right? You cannot explain the acid-base defect. Why? Because I can make more ammonium. Ammonium has a pKa that is well above 6, 7, it's in the 8s or higher, if I remember correctly. Okay, meaning I don't need to have very robust capacity at all for proton excretion. If I get ammonium to this urinary space, I should be able to dump as much proton as I want. Why? Because again, ammonium has a pKa where it is essentially a base. It will accept a proton. It leaves protonated. Okay, so how can you argue then, if this is just a distal defect, that ammonium excretion rates are low in distal RTAs? Does that make sense? You have to say that there's a problem with ammonium excretion rates. And so some people have said that distal RTAs are actually defects in which there is a problem with proximal tubular ammoniogenesis. Okay? Some people make that argument. Again, I don't need to have a urine pH of 5 in order to excrete protons, because again, ammonium is an avid proton acceptor. As long as I have a urine pH that's, even below 9, right? That ammonium is leaving the body protonated. Okay. So again, some people have said that distal RTAs actually have some component of proximal dysfunction. Okay. But the workaround is, well, even though I might have, ammonium delivery to this segment of the nephron, I have defects in ammonium transport. Okay, where's the, right. So ammonium transport is also a distal nephron function. Okay, and so I have problems with recycling ammonia in the distal nephron. I don't need to invoke a proximal defect. I can still say this is still a distal defect. It's just that the defect is not only in proton secretion, but also in ammonium recycling. Okay? All right. So again, preparing you for the Orson question, you'll say, he'll come up maybe sometime. It's not every year that he brings this up, but he'll say, okay, well, this doesn't make sense, right? pKa of ammonium is really high. It's 9, I think. So we shouldn't need to drive a proton or a urine pH down to the 5s in order to exhibit intact ammonium excretion rates in the setting of metabolic acidosis. And you can say, well, maybe there's a problem with ammonium recycling in the distal nephron, or maybe it's a proximal defect, and he will give you props. He's not effusive with his props, but he'll give you props for that. Okay, so that was okay, so I want to reinforce that distal RTAs do have impaired ammonium excretion rates. Okay, maybe it's a problem with this ammonium recycling or trapping in the form of ammonium with impaired proton secretion. But incomplete RTAs may differ from that, and maybe that's why it deserves a different category, because some people have described these patients, in order to achieve balance, they just crank up their ammonium excretion rates, okay, which would be different from a distal RTA. Okay. These patients, again, often have hypocitraturia. It doesn't take much in order to render your urine citrate low. So some people have described this incomplete distal RTA with a relatively normal serum bicarbonate as a subclinical acidosis, right? Acid excretion rate is a little less than my generation rate, but I'm able to achieve a relatively normal bicarbonate. It's a subclinical acidosis. Some people have called that eubicarbonatemic metabolic acidosis. Okay, how can I do that? I might just demineralize bone. I have buffers in my bone in order to maintain a serum bicarbonate that's normal, even though acid excretion rates are not matching generation rates. Moving pretty quickly. These are very complex concepts. Hopefully take the time to think about this or review the YouTube video if you didn't catch all this. Okay, I'm moving pretty quickly. Body buffers, bone buffers, ammonium recycling, proton secretion. Okay. Because nobody's slowing me down with questions. I'm moving. Okay. All right. Again, calcium phosphate nephrolithiasis is sometimes a presenting feature of an incomplete RTA. Hypocitraturia and high urine pH are the factors at play. And again, sometimes you get the overt distal RTA. Sometimes that is driven by the onset of nephrocalcinosis. Remember, I told you RTAs are sometimes, which happened first? RTA first, then nephrocalcinosis, or nephrocalcinosis and then impaired proton secretion and RTA. Okay. So some of these patients can develop into overt distal RTAs as that tubular injury mounts with the calcium phosphate deposition in the renal parenchyma. Okay. I mentioned how you diagnose these in the research setting with ammonium chloride loading, and then you look for a maximal urine acidification, a urine pH that drops to the low fives. But more often in the ambulatory setting, you'll give some furosemide plus some fludrocortisone, and you try and enhance proton secretion that way.
When do you check it after giving it? How fast should you see the change?
You'll see this within the first 6 hours. However, I always have to highlight the fact that in the you need to, your urine has hours of urine in it. Sorry, your bladder has hours of urine in it. So ideally, you should have somebody empty their bladder before this maneuver, and then you give the drug, and then you can check their urine pH within the next 6 hours or so. And this combination of drugs, fludrocortisone and furosemide. Okay, but sometimes you won't see the ideal scenario, especially if somebody hasn't taken the time to empty their urine because you're emptied their bladder and now the urine pH is the net sum of the urine that existed in the bladder prior to the maneuver. Okay. All right. Treatment really is focused on the nephrolithiasis because they really have a normal serum bicarbonate. You don't have to get too carried away with that. All right, let me just briefly cover voltage defect. I think I built out the framework for this, but I'll make a couple of points that we have to get to. Again, I either have a problem, at root of generating the lumen negative potential difference, right? And most commonly that's because of some problem with sodium reclamation. A reason I might have a problem with sodium reclamation is I just don't deliver enough sodium to this segment of the nephron because the patient has renal insufficiency or profound heart failure or profound cirrhosis, and they don't deliver much sodium to this segment of the nephron. Low aldo from any cause, the most common of which is the classic type 4 RTA, which is typically hyporeninemic, hypoaldosteronism. I might have aldosterone resistance. What would be an example of that? Well, mineralocorticoid antagonist. So mineralocorticoid antagonist causes metabolic acidosis. It's resistant to aldosterone. If I give you a ENaC channel blocker like amiloride or tramterine, that would be a form of aldosterone resistance. You can think of it that way. The known side effect of those drugs is metabolic acidosis. Okay. Other examples of, let's call a voltage defect that you're going to see pretty commonly is a sickle cell nephropathy. So this should be there if I've not, yeah. So sickle cell disease is a classic cause of a voltage defect RTA. For some reason, the distal segments of the nephron become, somewhat resistant to aldosterone, or ENaC channel activity is impaired in that scenario. Again, the ENaC blockade, either through the upstream antagonist of mineralocorticoids or the downstream blockade of ENaC. Trimethoprim and pentamidine are not used for their ability to block ENaC, but have a known side effect of blocking ENaC. And so you can see with high-dose Bactrim, a patient developed metabolic acidosis and hyperkalemia because of impairment in ENaC channel activity. Okay. Some people have described a dysfunction in sodium reclamation through obstruction. And then there are cases of aldosterone receptor defects in which it looks like hypoaldosteronism, but the problem is in the mineralocorticoid receptor. Okay. Um, so I think we can finish off this segment. Hyperkalemia, let me make this point, which is an important one, of any cause impairs urine acidification. Okay, so many times in these RTAs that involve hyperkalemia, the classic of which is the hyporeninemic hypoaldosteronism and the diabetic with moderate CKD, you can focus your treatment on the potassium problem, and the acidosis often gets better once the hyperkalemia improves. Okay, so how do we make sense of this? Hyperkalemia of any cause impairs my generation of ammonium in the proximal nephron. Okay, so let's go over that biology. It's going to be relevant as we talk about metabolic alkalosis as well, and hypokalemia causing metabolic alkalosis. So again, when I get hyperkalemia, most of that K resides in the cell, right? 98% of total body K is in cells. When I get K loaded, most of that K is buffered by the intracellular space. Protons leave the intracellular space as cations like potassium increase in the cell. Protons leave. If protons leave, then I get reduced glutamine transport in the cell. I get reduced metabolism of glutamine into ammonium, and so I generate less ammonium. So hyperkalemia of any cause impairs proximal ammoniogenesis. And if I can't make ammonium, and that's my main modifiable factor for modifying net acid excretion, I can't respond normally to an acidosis. So if I correct the hyperkalemia, and I restore my capacity to generate ammonium, often I can dump more protons in the distal nephron and the acidosis gets better. Okay? Hyperkalemia of any cause impairs ammoniogenesis. And so if you check a urine anti-gap in somebody who has hyperkalemia, you might expect a less negative or positive urine anti-gap. And you don't have to invoke, this is a distal RTA secretory defect. It's just correct the hyperkalemia and then let's repeat the urine anti-gap or the urine osmolar gap. Okay? All right, treatment, again, correct the hyperkalemia. Sometimes I do that with diuretics. That helps with the hyperkalemia. It also helps generate more lumen negative potential difference. We've gone over that multiple times. Get more sodium to the distal nephron. We absorb that sodium. I generate lumen negative charge. It helps dump more protons. As a treatment of last resort, fludrocortisone can be used. Many of these patients, again, have CKD. Giving mineralocorticoid to a patient with CKD is probably not a good thing. We use mineralocorticoid antagonists to treat CKD, and then also so it stands to reason giving mineralocorticoids would be potentially bad from a cardiomyopathy standpoint. It would also be bad from a volume standpoint. These patients are predisposed to volume retention by their CKD, and you can precipitate volume overload by injudiciously using fludrocortisone. So if you're going to use it, it should be used with diuretics if the diuretics therapy alone is not working. Questions? Okay, sounds good. We'll end it there.